So I'm going to be talking about thoracic surgery, and I'll explain that in a minute. I have the privilege of speaking to you, but I have to give a shout out. A lot of the people who work in the OR know Lawrence Spear, who's my colleague for the past, well, actually I worked with him 20 years ago, and then he joined us again about 8 years ago, and he is a master surgeon. He's like a pianist at a symphony. That's how good he is, so I want to give credit where credit is due. So what is thoracic surgery? Surgery basically of the chest, below the neck, above the diaphragm. There's a lot of things in there. The two main organs that we operate on are the lung, which I'm going to focus on today, and the heart. For the heart, we don't do robotic surgery here. We do it at NYU in Manhattan for certain very select procedures. So when we do surgery, what is surgery? It's just something really that needs an incision. So if we're going to do heart surgery, the incision of choice is what's called a median sternotomy, and this sounds very invasive, which it is, but it's really very well tolerated. It looks disfiguring, but people are up out of bed, they're home in a couple of days, and for heart surgery, there's only very few procedures that can be done robotically. But what we're going to focus on is lung surgery. Now, you say, a lot of patients say, oh, why do you have to go through the middle, go through the side? Well, actually, going through the side and spreading the ribs is much more debilitating. And years ago, before we did robotic surgery, people would be in the hospital for 5 to 7 days, multiple tubes, a lot of pain. And what you do is basically you have to split a lot of the muscles. You can see that big retractor to get to the lung. And we had to do it to do what we needed to do. You still want to do the right operation. So this is what we're going to focus on, and robotics has made a big difference. But the way it evolved, when we do it open, it's called thoracotomy. And a lot of people out there will hear of what's called thoracoscopy or video-assisted thoracoscopy, and we'll see it on the OR schedule as a VATS, and it's a common term, and it really works quite well, and we still do this VATS for certain procedures, but there's limitations to what you can get done and the visualization, and you're going to hear this, and when you see the demonstrations, it'll be amazing what the robot can do that you can't do with thoracoscopy. And the real difference is when you do thoracoscopy, the instruments are over there. They're basically arms. They're straight, rigid arms, and they open and close. And just imagine trying to do something if you had a splint on your wrist. You couldn't do anything. This is all you could do. You can get stuff done. You can push things away. And you can grab, but you have none of this. And then on the other side of the screen under robotic, you can see how you have full motion of the arm that's in the chest, and then at the end, that white part is what the machine runs. And I'm going to just show you quickly. Again, we only have 10 minutes. This is the instrument. This is the back of the instrument that connects to the robot with these dials that connect to gears, and it's amazing. You say, well, how precise can that be? And then it's going to quickly show you the tip, and it moves in all directions. And you say, okay, well, that's good. It's still this rigid metal bar, and you got all this contraption. What can you do? It must be dangerous putting this stuff in the chest. Well, this shows this is a grape that's been peeled. And this is not me doing it. I love to take credit for this. And you can imagine trying to do this even freehand. You're going to crush the grape. You can grab a suture that's the size of a hair, and you can put it through the skin. Let's see how gentle that is, and you can do this in a patient. This is not a mock-up. This is how, and you're going to see it when we do the demonstrations. And this is where the robotic has really changed everything. The other difference is you're seeing a 3D, this is only a 2D screen, but the surgeon is seeing 3 dimensions. I want to move it more if I can get to the end. I guess I can't. All right, well, anyway, you can see it sewing. I have a couple more minutes. And this is all being done through one little port. All right, I'm going to move along. So with video-assisted thoracoscopy, you do have the camera, which is good. You have no chest wall muscle cutting, which we did with the open incision, no rib spreading, less pain. But it's only 2D visualization. You have limited instrument mobility, limited dissection capability, and you really can't do a complete, delicate dissection. With robotic surgery, you get the 3D visualization, full instrument mobility, complete dissection, and it's quite delicate. So when we do thoracic surgery, it's mostly for lung surgery, and it's for patients say, what's the difference between a spot, a growth, a tumor, a nodule, or cancer? Not all spots are cancer. So you can have a nodule, a growth, a spot. It's all the same thing. The real issue is it cancer or not? And the treatment of choice for cancer is to take it out. And this just shows you a nodule in the lung, and you can have what's in the lung, solid nodules, partially solid, and there's something called ground glass. Because the lung has air in it, when you see it on a scan, sometimes it just looks like cloudy glass. This just shows you a lesion on an X-ray. X-rays are not great. It's faint. You have to be very well trained. A radiologist would find that. But on a CAT scan, it's quite obvious. And you can see the spot. And that's why now screening, just like Pap smears, colonoscopy, mammograms, now CAT scan is the standard for screening. And it's not just taking out the nodule. The other thing with chest surgery is the lymph nodes. It's important for treatment, it's important for staging, and you have to be able to get to them. This just shows a patient, a CAT scan of a 55-year-old woman with a left-sided lesion. You see pointing there. And then you've heard of a PET scan. A PET scan will show the lesion, but we give a chemical, it's glucose with radioactive material, and it signifies that this could possibly be cancer as it lights up. You can see the bright yellow, and also there's bright yellow in the center, which is also suggestive that lymph nodes are involved. I'm sorry, yeah, this has some audio I couldn't get rid of. But anyway, this just shows you the patient positioned with the marks, and that's what what's called the ports inside, and that's what the robotic arms go through. Okay, I got 2 more minutes, I think. This just shows you what we see in there. This is the lung. The lung has multiple lobes. That's a natural split. That's the way we're born. Looking deep, that pale area is what's called the pulmonary artery. But you have full visualization, full mobilization of the lung. The reason you have that black spots, it can be from smoking. It's called anthracosis, or blackening. It can be from living in the city. And that's what that's from. If you get a very young person or someone who's never smoked, lived in the country, it'll all be pink. Okay, that's the lung. And with lung surgery, let me start this. This is us getting around the artery, the pulmonary artery, which is a very delicate structure. And if it tears, it really can turn into a catastrophe. You have to open the chest. And this is where that gentle motion of the robot you saw with the grape becomes so important. And then people also ask, well, once you get the lung all separated and cut and you got to take it out, how do you get it out of these little incisions? And let me move on. This is a bag that we put in through one of those holes. The hole's a little bit bigger than the other ones. It goes in the bag, and then you can pull it out safely. And really, robot has been a game changer. They're in the recovery room for about 3 hours. There's no ICU required. They're usually home in 48 hours, a lot less discomfort. Restrictions are minimal. We used to not let them drive for a month, not go to work for a month or 2. Now we say, do what you feel you can do. Maybe not go to the gym for a week. And the other most important thing, we have this minimally invasive thing. Oh, isn't that great? But if you're doing it minimally invasive, but you're doing the wrong operation, you're not helping anybody. We're getting all the lymph nodes, we're getting a complete dissection, and I actually think you're getting a better cancer operation than if you do it open. And then one thing last I want to end with, I don't want to get too emotional, but anyway, we have all this technology. It's wonderful. It's been a game changer, whether it's bariatric surgery or hernia surgery. You're going to hear about gynecologic surgery. But a lot of people here are from the NYU, Langone, Long Island, previously Winthrop team. And I stay by this quote: the secret of care of the patient is caring for the patient. And I see the intra-op nurses, the peri-op nurses, my surgical colleague, and those people who don't know NYU Long Island, and I still go Winthrop, I've been here that long. We have one of the most caring teams I've had the privilege to work with. And I want to thank everybody here. Thank you.